Management of Malignant Pleural Effusion, British Thoracic Society Pleural Disease Guideline 2010. So the first paragraph is about introduction, in which guidelines explain if malignant cells are present in pleural fluid or pleura, it signifies advanced or disseminated disease and patient have low life expectancy. The median survival is about 3 to 12 months. The majority of the cancer which are causing pleural effusion in males, it's the lung cancer, and in females it's breast cancer, which constitute about 50 to 65% of all the malignant effusions. Then the rest of 25% are lymphomas, tumor of genitourinary tract, GIT tract. Then one most important point clarified by the guidelines that low pH does not reliably predict a survival of less than 3 months. The only significant thing which is associated with mortality is performance status of patient. Then second portion was started with a clinical presentation. So the majority of the patients are symptomatic. Majority of the patients who are having pleural effusion, malignant pleural effusion, they are symptomatic. Massive effusions are due to malignancy. It will explain the massive effusion definition later on, but to keep in mind, if the patient is having a massive effusion, it's likely because of malignancy. But in 25% of the patient, it could be asymptomatic and patient does not experience any symptom. The clinical features, mostly patients are with dyspnea. And why it is occurring? The dyspnea is occurring because reduced compliance of the chest wall, depression of ipsilateral diaphragm, mediastinal shift, and reduction in lung volume. So the reason for dyspnea, as the fluid is already present there, compliance of the chest wall will be reduced. The diaphragm on the same side will be depressed, mediastinum will be shifted, and lung volume reduced. And all these combine leads to dyspnea. Some patients may experience chest pain as well due to the involvement of parietal pleura, ribs, or other intercostal structures. A very good definition of massive pleural effusion, how we are going to define massive pleural effusion: complete opacification of hemithorax on chest X-ray. The third part starts with the management options. So what are the treatment options available for malignant pleural effusion? Before going towards the treatment options, we need to consider the treatment options depend on certain things. First of all, how patient is symptomatic or not. What is the performance status of patient? What is the primary tumor? Is it responsive to therapy? How about the degree of re-expansion of the lung? On these bases, we decide about the treatment options. Options which are available are: number one is observation. We don't do anything and observe. We could do therapeutic aspiration or pleural tube drainage or pleurodesis or indwelling pleural catheter or thoracoscopy with pleurodesis. Let's go towards when to choose which option. There's a very good flow chart. So first of all, you should know that this is the malignant pleural effusion. Cytology is positive. The test for the malignancy are positive. You confirm that this is the malignant pleural effusion. Then second most important or top most important thing is symptomatic. Is the patient symptomatic or not? If the patient is not symptomatic, we can only observe it and don't do anything. And advice should be sought that if patient becomes symptomatic, he has to return to the respiratory medicine and further options can be discussed with him. Second option we have aspirate. Aspirate to relieve symptoms like 0.5 or 1.5 ml of fluid can be aspirated, but this decision is made on the prognosis. If prognosis is less than 1 month, then we can aspirate as to control the symptoms, or like for palliative management, for symptomatic management, you can aspirate it. Recurrent aspirations can be done, but the prognosis is less than 1 month. Should not remove more than 1.5 liter on a single occasion. We'll discuss it later. But if the prognosis is more than 1 month, then the next option we can do and find out if it is a trapped lung or not. If it is a trapped lung, then you cannot go for pleurodesis. If it is a trapped lung, yes, complete trap, yes, then pleurodesis is not going to work. Go for IPC, indwelling pleural catheter. If it is not a trapped lung, we can go for effusion drainage plus minus pleurodesis. So we can put a chest tube and then try with a pleurodesis. Either can be done, like the intercostal tube or thoracoscopy and talc podrage can be done. We have done the drainage, we have done the pleurodesis, and still we are knowing that it could be a trapped lung. As soon as we got to know the word trapped lung, we are going to go for IPCs. If it is not a trapped lung, after the tube we can go for talc slurry or thoracoscopy and talc podrage. It is successful, good, stop here. If it is not successful, then consider indwelling pleural catheter or repeat pleurodesis. Depend upon the thing. One important, there is no evidence as to what proportion of unopposed pleura prevents pleurodesis. We suggest that less than 50% pleura position is unlikely to lead to successful pleurodesis. Now, let's discuss these options in detail. Observation. When to do observation? If patient is asymptomatic and we know what kind of tumor it is, we can observe and we can ask the patient to return back to the clinic or the ward or anything, and we can decide on further management plan. Second, we talk about aspiration. If the life expectancy is less than 1 month, we can go for aspiration. 1.5 liter of fluid on single occasion can be removed. Plus, if at any point in time patients become symptomatic, complaining of chest pain, discomfort, or cough during the procedure, we should stop it. It has a very high reoccurrence rate and a small chance of iatrogenic pneumothorax would be there. Next option. So next option is tube drainage and pleurodesis. Tube drainage is preferable to recurrent aspirations, especially followed by a pleurodesis. Unless it is a trapped lung, then you cannot go for pleurodesis. But if it is not a trapped lung, we can go for pleurodesis. What is pleurodesis? What is the role of pleurodesis here? It is a diffuse inflammatory reaction and local activation of coagulation system and fibrin deposition. In animal studies, corticosteroids and NSAIDs impairs the action of pleurodesis, but there is no evidence from human studies. For drainage, which tube to select? So size of the tube could be 10 to 14 French. Large bore tubes causes more pain. It was initially been thought that large tubes gonna be beneficial as it's less prone to obstruction by the fibrin plugs, but there is little published evidence to confirm this, and it is more painful. So we can go for a small bore tubes 10 to 14 French. How to perform a talc slurry chemical pleurodesis? Small bore intercostal tube 10 to 14 French. control evacuation of the pleural fluid, confirm that full lung re-expansion and apposition of intercostal tube with chest X-ray. In case where incomplete expansion occur, we have to go for a trap lung. Administered lidocaine 3 milligrams per kg, maximum 250 milligrams, and then use a graded talc of 4 to 5 grams in 50 ml normal saline. Clamp it for 1 to 2 hours and remove the tubes in 24 to 48 hours if the drainage is less than 150 ml per day. Now coming towards a fluid drainage, pleurodesis and trapped lung. Large pleural effusions should be drained in a controlled fashion so that we can reduce the risk of re-expansion and pulmonary edema. In patients where only partial pleural apposition can be achieved, chemical pleurodesis can still be attempted and may provide a symptomatic relief. In symptomatic cases where pleural apposition cannot be achieved and there is a trapped lung, then induling pleural catheters offer a more attractive therapeutic approach than a recurrent aspiration. Once effusion, drainage and lung re-expansion have been radiographically confirmed, pleurodesis should not be delayed. So we should not delay it. If need to apply a suction, then it should be high volume, low pressure, and it can be up to -20, but start with lower. Before pleurodesis, amount of pleural fluid drain should be less than 150 ml a day. So let's talk about analgesia and pre-medications. As we discussed, lidocaine 3 milligrams per kg. So whatever the weight of the patient, you multiply it by 3, and the maximum you should be thinking that it should not exceed 250 milligrams. Intrapleurally should be administered prior to your talc, and pre-medication should be considered because patient may have pain, anxiety with the pleurodesis, and it is really painful procedure. For the selection of agent, talc is the most effective agent according to these guidelines. Graded one should be used. In graded, the particle sizes 15 micrometer. Then graded slurry can be used. It has a success rate of 81 to 100. The graded talc decrease the risk of arterial hypoxemia. Alternative to talc is bleomycin. And the side effects associated with talc: chest pain, fever, ARDS, and pneumonitis. Talc is asbestos free. It has two forms, podarage and slurry. Slurry is a suspension form given via chest tube, and podarage using atomizer during thoracoscopy. Alternative is bleomycin, 60,000 units in normal saline. It is not superior to talc. There is no benefit of rotating the patient after the procedure. As we discussed earlier, clamp the tube for 1 hour and can be removed within 24 to 48 hours. So, if pleurodesis fail, if there is a trap lung, high likely chances that pleurodesis is going to be fail, and pH is no longer linked with pleurodesis failure. Initially, it was being thought. The complications of IPC drains or chest drains is malignant seeding, especially with the mesothelioma. So in these cases, prophylactic radiotherapy can be given at the site so that reduce the malignant seeding. Intrapleural fibrinolytics can be given for relieving distressing dyspnea due to multiloculated malignant effusion. It could be streptokinase, or more appropriate is urokinase. Second is about thoracoscopy. So the diagnostic yield for thoracoscopy is about more than 90% for malignant pleural effusion. Talc podarage success rate is 77 to 100%. As we discussed for celery, it was 81 to 100%. So it's for both it is good. It is superior to bleomycin and tetracycline. Slurry and talc are equal. It is a safe procedure. Mortality is less than 0.5%, but in some patients, empyema and respiratory failure can occur. Secondary to infection and re-expansion pulmonary edema. Long-term ambulatory IPC drainage can be done if the patient is having recurrent effusions or patient is very symptomatic. For pleurodesis, doxycycline can be used. For IPCs, it has a shorter. So as compared to the pleurodesis and IPCs have a shorter hospital stay and decreased rate of failures, late failures especially. But complications are more with IPCs. And it is more good if there is a trapped lung and patient have a low life expectancy. Complications with IPCs are local cellulitis and tumor seeding, especially with mesothelioma. There is one more option, pleurectomy. Open pleurectomy has a more morbidities, empyema, hemorrhage, respiratory failure. VATS is also one of the procedures by which pleurectomy can be done, but currently no randomized controlled trials are available to think it of as an alternative.